Hello, welcome to the DO webinar. I'm Professor Byung-ho Choi at Yonsei University in Korea. Today's topic is digital Oron 4 and Oron 6. I'm focusing on how to implement Oron 4 and 6 efficiently. I'm talking about today many issues, such as what type of multi-unit apartment is optimal for the procedures, what type of Ziegler is useful for connecting an angulated apartment to distal tilted implant, what type of temporary cylinder is ideal for the procedures, how to perform guided implant surgery precisely, how to fix a surgical guide accurately. And finally, I'm going to talk about what type of final restoration we should make for Oron 4 and 6 implant treatment. This video shows the concept of Oron 4 implant treatment. Using 4 implants, you can fabricate a full arch fixed prosthesis. This slide shows Oron 6 implant treatment. Using 6 implants, you can fabricate one-piece full arch fixed prosthesis. I like the Oron 6 implant treatment rather than Oron 4 implant treatment. But in a severely atrophic region, if you can't place 6 implant, this Oron 4 implant treatment can be a good option. If you place implant like this, 4 straight implants between the mental nerves, it increases the cantilever length. If the prosthesis has too long cantilever, it can cause fracture of the prosthesis. Therefore, we need to try to decrease the cantilever length. If you place tilted implant like this, you can decrease the cantilever length. In the maxilla as well, you can place tilted implant like this. You can decrease the cantilever length of the prosthesis. For Oron 4 and 6 implant treatment, you need a multi-unit abutment. There are 2 types of multi-unit abutment, which are straight and angulate abutment. If you look at the straight abutment, there are different cup heights available. You can choose one of them based on the thickness of mucosa. The connection part of the abutment is generally non-hex. If you look at the lower part of the abutment, there is a screw thread. As a result, you don't need an additional screw to fix the abutment to an implant. The straight abutment comes with a pre-mounted holder, which helps connect the abutment to an implant. Let's take a look at an angulated abutment. This is an angulated abutment. This is a cross-sectional view of the abutment. It contains two screw access holes. The abutment screw is inserted into the distal screw hole, like this one. And the cylinder screw is connected to the abutment from the top. There are different angulations available. There are different cuff heights available. The angulated abutment has generally hex connection. Therefore, you need to orient the hex of the abutment to connect it to an implant. There are some problems with the multi-unit abutment. The most common problem is screw loosening or screw fracture. This tiny screw can be loosened or can fracture. The main reason for the screw fracture or screw loosening is stress. The most stress is concentrated on the distal implant, especially on this tiny screw. We need to reduce the stress on the screw to prevent screw loosening or screw fracture. How to reduce the stress? We designed 6 different types of abutment. The number 1 has a short, narrow screw and short abutment. Number 2, short, wide screw and short abutment. Number 3, long and wide screw and short abutment. Number 4 has a short and narrow screw and long abutment. Number 5 has a short, wide screw and long abutment. And number 6 has a long and wide screw and long abutment. We did a 3-dimensional finite element analysis. We applied this cantilever loading of 200 Newton centimeters in the molar region of the metal plate. And then we evaluated the stress distribution on the screw. Which one do you think will get the least stress on the screw? You may think that number 3 or number 6. Our result show that the number 6 has the least stress on the screw. The wider and the longer the screw was, the less the stress was. The higher the abutment was, the less the stress was. Therefore, we would like to recommend to use wider screws and longer abutments to reduce the stress on the screw, to prevent screw loosening or screw fracture. You can see here a long and a short abutment in the mouth. There are different types of multi-unit angulated abutment on the market that are fabricated by various implant companies. They all have a short, narrow screw and a short abutment. Why they have not increased the screw diameter? Why they have not increased the abutment height? Or why they have not been able to increase the abutment height. The abutment height has a close relationship with the tape of the abutment. This shows the degree of tape of the abutment. It determines the range of compensations for the errors that occur in implant placement. If you are not able to place all implants parallel, you have to use a short abutment to make one piece of framework. If you are able to all implant nearly parallel, you can use a high abutment. Then you can make a one-piece framework. In the past, surgical guides were not available. You were not able to place implants precisely. Now, surgical guides are available. We can place implant more precisely using the surgical guides. I would like to recommend to use long abutment to prevent screw loosening and screw friction. This video shows Oron 4 implant planning to minimize the cantilever length. You can see here the AP spread and the cantilever. The AP spread is the distance between the most anterior implant and the most posterior implant. If you increase the AP spread, the cantilever length becomes shorter. By maximizing the AP spread, you can minimize the stress on the screw. Let's move on to another issue. What type of jigger is useful for connecting angulated abutment to a distal tilted implant? This video shows connection of a multi-unit angulated abutment to distally tilted implant. It looks like it's easy to connect it to the implant, but the reality is completely different. It's highly dangerous, very difficult. Anyone who have ever experienced Oron 4 implant procedure say that one of the most difficulties in the Oron 4 procedure is the connection of the multi-unit angulated abutment to the distal tilted implant. Because of poor visibility, because of the poor accessibility, the angulated abutment is connected to the implant from distal side. And the abutment screw is also inserted into the abutment from the distal side in the mouth. It's quite challenging. Nobel Biocare provides this type of jig to connect the angulated abutment to the implant. You can fabricate the jig on the model using pattern resin. Even though you use the Nobel Biocare Ziegler, it's still quite challenging because the screwdriver access hole is located on the distal side of the abutment. You can't see the screwdriver access hole. That's why it's quite challenging. On the left-hand side, it's a lot more challenging because you have to use your left hand to tighten the screw. Let me show you a clinical situation that I have experienced. I tried to connect the angulate abutment to an implant with my hand, but I couldn't. And then I tried to connect it using a handpiece, but I was not able to get a sense of connection to the screw. It was quite stressful. I got a lot of stress at that time. That's why we have developed a distal Ziegler. This is a distal Ziegler. You can tighten the screw using a ratchet. You can connect the angulate abutment to an implant. Let me show you how to fabricate the distal Ziegler. After implant planning, a crown is designed on the abutment that is connected to posterior implant. Two panics are designed on the medial side of the crown. Screwdriver accessor or screwdriver holder is designed on the distal side of the crown. The designed Ziegler is 3D printed. And then you need this titanium temporary cylinder with a lateral opening. The cylinder is connected to the Ziegler. And then an angulate abutment and the screwdriver is connected to the Ziegler. The combination is moved into the mouth as one body. And then using ratchet, you can tighten the screw in the mouth. You can orient the hex of abutment using the panics. Panics is aligned with the alveolar ridge. Using the panics, you can orient the hex of the abutment. Let's move on to another issue. What type of temporary cylinder is optimal for the Oron 4 and Oron 6 procedures? Cylinders are needed to fabricate provisional screw-retained prostheses. The cylinders are bonded with the denture using light-curing resin. To do the bonding efficiently, you need a wide exposed cylinder area beyond the rubber dam. There are different types of cylinder on the market. You need to adjust the cylinder height. The top of the cylinder should be below the occlusal surface. If you adjusted the cylinder height in the mouth, During surgery, it takes a lot of effort. It takes a lot of time. Therefore, you need to adjust the cylinder height in advance before surgery. This shows how to adjust the cylinder height before surgery using provisional denture and the 3D printed model. You can trim the cylinder. After adjusting the cylinder height, after placing the rubber dam beneath the cylinder, the exposed cylinder height becomes shorter. There you can see here different exposed cylinder height. I would like to recommend to use this type of a cylinder that has a wide exposed cylinder area beyond the rubber dam to do bonding process efficiently. You see here long cylinders exposed beyond the rubber dam. You can bond them with the denture efficiently. Let's move on to another issue, how to perform guided implant surgery precisely. First, let me show you this patient. She had an edentulous ridge in the mandible. She had been wearing this denture for more than 10 years. Let me show you the condition of her denture. Her denture is floating.
말을 해도 빠지고.
말을 해도 틀니가 빠지고.
예. 잘 씹어 먹지도 못하고.
씹어 먹지도 못하고.
예. 먹고 따로만 지들 먹는데 따로만 다니고 그랬지.
가서 먹지도 못하면서.
예. 먹지도 못하면 따라다니고.
On her birthday, she was invited to a dinner by her children. What she was able to eat was only a soup. She wanted to get a normal life. Let's take a look at her mandible. Her edentulous ridge was nearly flat. The CT scan showed severely resolved alveolar ridge. We planned Aurum 4 implant treatment. The first thing we did was to take impression using the existing denture. This shows after taking impression, you can see here marker traces. Using an intraoral scanner, we scanned the denture. This is the scan image of the denture base. We inverted the scan image of denture base. If you invert it, you will get this intraoral edentulous ridge image. We took a bite scan. You need to replace the denture image with the edentulous image. Then you will get the edentulous ridge image and the opposite teeth image having the vertical dimension. Then two scan images were merged using these intraoral markers. The markers were secured in place using a special glue, which is Hysteroclear. On the merged image, we did implant planning. Aurum 4 implant planning was performed. We designed a surgical guide. Using this 3D printer, we fabricated a surgical guide. In a dangerous patient, you can often have this sharp alveolar crest. You need to make to remove the sharp alveolar bone. If the bone surface is not flat, the drill can slip on the slope. You can make the bone surface flat using this bone flattening drill. This is the bone flattening drill. It has markers. Using the markers, you can control the depth of the drill. You just need to insert the drill into a surgical guide and drill. By drilling, you can make the bone surface flat. Dr. Marlowe has published several papers about Aurum 4. In one of his papers, he said that the contraindication of the guided frameless Aurum 4 is insufficient mouth opening. The mouth opening should be at least 50 millimeters. Could you imagine how wide it is? 15 millimeters mouth opening. This guy can open his mouth up to 40 millimeters. This man can open his mouth up to 50 millimeters. It's very hard to find that kind of person who has such a wide mouth opening. As a result, some companies use the lateral opening site to place drills in the surgical guide. Let me show you one implant company's guide system. The guide system uses the lateral opening site, even though the guide system uses this lateral opening site. Your patient have to open their mouth up to 48 millimeters to place an implant in the mandible, in the posterior area. You can see here the interference between the top of the handpiece and the opposite teeth. Even though the surgical guide has the lateral opening site, the dentist had a difficulty in placing the drill in the right angulation due to the interference. How about your guide system? You can place the drill directly into the surgical guide. You don't need the lateral opening site. DO guide system need only 35 millimeters of mouth opening to place implant in the molar area. There is a huge difference between A company's guide system and the DO guide system in the space required to place implant in the molar area. 48 and 35 millimeters. If you use a DO guide system, you can place implant in the molar area without difficulty. What's the difference between them? Look at the drill length. There is a big difference between A implant company's drills and DO drills. Even though DO use more number of drills to place on implants, the drill length is a lot shorter than the A company's drills. The second reason is offset. Offset is the distance between the top of the surgical guide and the top of the implant. If you increase the offset, the drill space becomes decreased. Your patient have to open their mouth wide. You see here different offsets values from different companies. DO has the lowest offset value among them. I would like to recommend the guide system that has a low offset value. This patient has a very limited mouth opening who want to get an implant in the mandibular second molar area. The mandibular second molar area is the most difficult area to place implants using a surgical guide. Do you think it's possible to place an implant in the area using this drill that has 38 millimeters of drilling length from the top of the drill to the tip of the from the top of the handpiece to the tip of the drill? I don't think it's possible. How about this DO drill? The drilling length is only 28 millimeters from the top of the handpiece to the tip of the drill. I think it is possible. You can see here, an implant is placed in the mandibular second molar area without difficulty using the DO guide system. This shows drill tolerance, which is the space between the drill and the surgical guide. If there is a large tolerance, the drill can be deviated. Therefore, some guide system uses zero tolerance. We call it a direct drill guide system. There's no space between the drill and the surgical guide. If you use this zero tolerance guide system, you can drill more precisely. This is a guide, surgical guide having zero tolerance. You can see here, drill is very precise. No deviation of the drill. But the drill cuts the surgical guide. You can see here, resin debris is falling due to the lack of tolerance. The resin debris can enter into the osteotomy site along with the implants, along with the drill. You can see here resin debris in the mouth while drilling due to the lack of tolerance of the surgical guide. How about toxicity of the resin debris? You may be concerned about that. We did an experiment to evaluate the toxicity of the resin debris. We collected some soft tissue specimen from patient, and then we cultured the soft tissue. You can see here, cells are growing from the soft tissue segment We put titanium fragments and resin fragments on the culture plate. After 2 weeks of culture, all cells surrounding titanium fragment were growing, but all cells around the resin fragment were dead. This shows electron-microscopic views. On the titanium fragment, cells are alive, but on the resin fragment, cells are dead. These are resin microparticles. These are fluorescent resin microparticles. We put fluorescent resin microparticles in the culture media. The cells are eating micro resin particles, like a fish in the ocean eating plastics. The fluorescent resin microparticles stayed inside the cells, and the cells are dead. Resin is known to be harmful to human bodies because it can cause cancer, mutation, and inflammation. Therefore, I would like to recommend to use surgical guide that has a titanium sleeve to protect our body. This shows a long guide tube. If you use the long guide tube, you can drill more precisely. Using the guide system, you can place Oron 4 implants or Oron 6 implants more precisely and more safely. Let's move on to another issue, how to fix a surgical guide accurately. We need a bite registration body to position the surgical guide in the edentulous region. This is a bite registration body, which is a kind of intraocclusal record. This video shows how to fabricate the bite registration body. Body is placed between the surgical guide and the opposite teeth. The model has a vertical dimension. This is a completed bite registration body. This video shows drilling for an anchor screw and placing an anchor screw. If you take a close look at the drilling, the drill is deviating. You can see here the drill axis is deviating. If the drill axis is deviating, the surgical guide can be deviated. Then your implant placement can be displaced. Therefore, it's very, very important to fix a surgical guide precisely. How to fix a surgical guide precisely? You can see here 2 types of sleeve, a short one and a long one. This shows a short sleeve and a long sleeve. We compared the accuracy between the long and the short sleeves. We fabricated 2 types of surgical guide. The first one with a short sleeve and the other one having a long sleeve. We placed implants using two types of surgical guide in the 12 edentulous mandibular models. And then we evaluate the accuracy of implant placement by comparing the planned and the placed implant positions. The results show that the long sleeve group had a higher accuracy of implant placement because the long sleeve guided the drill more accurately. If you use a long sleeve, the anchor part is raised. You may be concerned about there is some interference between maybe interference with the use of a surgical instrument. Let's take a look at whether there is an interference between the drill and anchor. There is no interference between the handpiece and the anchor screw. You can use 2 anchor screws or 3 anchor screws to fix a surgical guide. On the left-hand side, the surgical guide is fixed using 3 screws. On the right-hand side, the surgical guide was fixed using 2 screws. We compared the accuracy between them. The anchor screw in the middle at the anterior side of the surgical guide is likely to dislodge the posterior part of the surgical guide. Look at the video. The anchor in the middle dislodged the posterior part of the surgical guide. If the surgical guide is dislodged, your implant placement can be displaced. We try to fix the surgical guide using 2 anchor screws that are placed symmetrically on either side of the surgical guide. You can see here the 2 anchor screw fixation method fix the surgical guide more precisely. We would like to recommend to use this 2 anchor screw fixation method. You see here an anchor pin and an anchor screw. If you use an anchor pin, you can push it manually into a hole in the bone. The anchor screw has a screw thread. Therefore, you need to drill it into the bone. The anchor screw has a stronger holding force than the anchor pins. Therefore, if you use the anchor screw, you just need 2. But if you use the anchor pins, you need 3. The ideal diameter of the anchor screw is 2.0 millimeter. If you use a smaller diameter of the anchor screw, it can fracture, especially in the mandible, in the hard bone. It can fracture. let's move on to our final issue. What type of final restoration we should make for Oron 4 and Oron 6 implant treatment? This is a scan image of the provisional prosthesis. Using the image, you can design the metal framework. You can fabricate it by milling. This is Oron 4 final restoration. Let's talk about Oron 6 final restoration in the mandible. First, I want to show you this case. He had an edentulous ridge in the mandible. 6 implants were placed in the mandible, and one piece of full arch fixed bridge was fabricated. This is one piece full arch zirconia bridge. The bridge was placed in the mouth. 6 months after the final restoration, we had no problems. 1 year after the final restoration, no problems around implants. Look at that. 2 years after the final restoration, you can see bone loss around this molar implant. Only one molar implant there was bone loss. Look at that, the bone loss around the molar implant. The other implants had no problems at all. What's the reason for that? The mandibular dynamics seem to be the main reason for the bone loss, because the mandible exhibit considerable movement during biting, such as a flex or a torsion. The amount of mandibular movement has been measured to be as high as 800 micrometers in the molar region. We have experienced serious consequences due to the mandibular dynamics. You see here mandibular reconstruction with mandibular reconstruction plate. The plate was fractured due to the mandibular dynamics. We reconstructed the mandible using a fibula bone graft and titanium plates. The bone was okay, but the plates were fractured. In implant treatment, the metal framework joining bilateral molar implants in the mandible should not be the treatment of choice due to the mandibular dynamics. This is our protocol. Before the osseointegration period, you can fabricate one piece of a prosthesis. After the osseointegration period, the prosthesis is sectioned into 2 pieces, and then they are replaced in the patient's mouth. The section site is between the canine and the first premolar sites for the aesthetics of the prosthesis. This protocol has advantages. Before the osseointegration period, the stress on the implant is distributed by splinting all implants together with a strong, rigid framework. After the osseointegration period, the prosthesis becomes stable in terms of the mandibular dynamics by sectioning. How about Oron 4, final restoration in the mandible? You don't need to worry about the mandibular dynamics because the mandible between the mental foramen is quite stable in terms of mandibular dynamics. You can make one piece of fixed bridge for Oron 4 implant treatment in the mandible. How about Oron 6 final restoration in the maxilla? You can make one piece full arch fixed prosthesis. Let me conclude my presentation. I have been talking about a long abutment to reduce the stress on the screw, a zigzag to connect angulate abutment to an implant efficiently, a cylinder type that has a wide exposed area beyond the rubber dam. I talk about the guide system having zero tolerance, a surgical guide having long sleeves, 2 anchor screw fixation method to fix the surgical guide, and the mandibular dynamics. If you consider all these things, I'm sure that you can implement Oron 4 and Oron 6 implant procedures more accurately and efficiently. Thank you for your attention. I hope you enjoyed today's lecture. See you soon again. Bye-bye.